So yeah, just like we mentioned last time, you know, I can't give very specific instructions on your particular medications since I don't know your medical history. Some of you I do, but not all. And if there's any questions after this, please talk to your Parkinson's doctors. Don't make any changes until you've talked to them as well. So that's just my disclaimer here. That being said, you know, I think there's been a lot of interest, and a lot of what we do in clinic is just trying to explain, you know, what these drugs are, how we make the decisions on what to use and when, and why we would change things and when and how. And I got to say, I've always mentioned to patients that, you know, my job as a movement disorder specialist is always safe, because these are complicated decisions that need to get made about how to do medication adjustments. So with all that said, I want to try and get into a lot of the non-levodopa containing medications. We had a long discussion last month about levodopa and, you know, how and when we use it and sort of the history behind how we got to levodopa. And sort of picking up that next phase of the history here, I think the dopamine agonists are a really good place to start. So dopamine agonists are medications that were developed, I think in the early 90s is when these were first being developed. And the whole idea behind dopamine agonists was that people were getting frustrated with having to take so many doses of levodopa over the course of the day. And there was good reason for them to think that with something like a dopamine agonist that we could get that extended benefit over longer periods of time. And that means that you don't have to take as many pills in a day, and that you get a more stable amount of dopamine that gets triggered during the day. So dopamine agonists were thought to be a game changer, and when they came out in the 90s. And just to kind of back you up as to what is a dopamine agonist. And so what we're showing you here is this diamond that you see here. This would be like dopamine. So this is the normal dopamine that you would have in your brain now. And we know that dopamine's there because there's a receptor that recognizes that there's dopamine. And when the receptor, let me put my laser pointer on here. So this would be like the dopamine. When it is noticed by the receptor, you get a change inside the cell that says we've been triggered. There's a signal coming saying the dopamine's here. And in the case of movement, this is to speed up movement or slow, you know, reduce tremor, things like this. And when you have less dopamine around because of Parkinson's, then that triggering just isn't happening. And so the idea was to make medications that either directly replace dopamine, and that's what we're doing with levodopa. So we're basically making more dopamine to get this activity to change. And in the case of an agonist, we have a medicine that behaves and mimics dopamine. And so you can see this edge looks like this edge here. And so it's noticed by the receptor, and the receptor is tricked into thinking that it's dopamine. And then by doing that, you get the same cascade of effects once that drug meets with the receptor. Now, contrary to that, we have antagonists. So just like in the story, the antagonist, the protagonist, the antagonist actually blocks. And so it does the exact opposite of what the agonist would do. But again, this is where dopamine agonists came into play. Is again, they mimic and pretend like they are dopamine. And that's how they are seen by the brain. Come on.
Sorry, I'm still
oh my goodness. All right, so there are some examples of dopamine agonists we have listed here. Okay, so a long time ago, and I mean, as far back as, even the 1900s, they were using bromocriptine. So this is a very old medication. I personally have never used this. I don't know anyone who still prescribes this. There are some insurance companies who suggest this as a medication to try as an alternate to other things, but this is just not used anymore for Parkinson's. There are a few other pituitary problems and some other things like that where we see bromocriptine, but this is typically not used anymore in Parkinson's. Pergolide had been very commonly used. And these two were some of the first dopamine agonists that were created. There were some issues with what we call fibrosis. So this like almost like a scarring of like the heart tissue. And there were some other problems that came up with these medications. And so they really fell out of favor and are not being used. Though in some other countries, this is still, you can still get these. Now, the ones that are really more available today, and many of you may know of them, have been on them or are currently on them, is this group of dopamine agonists we have listed here. So some of the most common ones are ropinirole, rotigotine, apomorphine, and pramipexole. You can see their brand names here. There are a couple versions of apomorphine, for example, but the one that is used often here in the United States is this injection, and really to kind of help with sudden offs, for example. A newer one is this Nupro patch. So this was actually created many years ago, and there were issues with the patch. It got pulled off the market. They came back, reformulated the patch, and so it's back and available now. You know, patients have often tried maybe a couple of these at some point, but there's many here that you can that you may be familiar with. So it's just the list. Now, it should be no surprise that there are side effects. There are side effects from any kind of medication, but these are the more common types of side effects that we see with dopamine agonists specifically. So very similar to levodopa, you can get nausea with these meds. This can be pretty common for some people. Sometimes this gets better over time, just getting used to the medicine and just adapting to it. But this is a fairly common one. For a lot of people, especially for people who are a bit older, so we usually say over 70, 75, there can be issues with confusion, actually seeing things that aren't there or thinking things that are happening that are not happening. So these are the more scary type of side effects that I think people really worry about. But this can happen with a dopamine agonist. This can happen with levodopa too. So it's not just this class of medications, but this tends to be a bit more of a problem with this type of medicine. Typically, I think it's incredibly important to have that discussion before you start something like a dopamine agonist, so that you know that if something like this comes up, you're not surprised and that your family's not freaking out, and that you know that it was probably the medicine that did it. And typically what I tell people is if it does happen, it's probably the medicine. And then we know we can make changes to try to mitigate or reduce those symptoms from happening. For a lot of people, there could be swelling or edema that occurs typically in the legs and feet. This typically also goes away if we stop this medicine. There's vivid dreaming. So just again, these really brilliant dreams that stick with you. This is a pretty common one with dopamine agonists, but other medicines and just Parkinson's itself can do this. And just like levodopa, it can drop your blood pressure and cause problems with sweating. This sleep attack is actually pretty unique to dopamine agonists. So when I say sleep attack, I mean, you are driving and you just pass out all of a sudden. So this is a huge concern. This is another one that needs to be thought of before you prescribe, before you take it, just to know that this could be an issue. When I hear patients tell me that they're suddenly falling asleep when they don't want to, it's probably we need to change the dose or think about trying some other medicine. This one really worries me for people who are maybe younger and driving. That's very unsafe. And so we need to know if this is an issue. It can affect other sleep issues as well, but it's the sleep attacks that are kind of unique to this medicine. And if something you're experiencing, you really should talk to your doctors about that. Now, this last one is this impulse control disorder. I'm going to spend a little bit of time here because this is a big issue with this class of medicines. And I want to make sure that everyone is aware of this, what these are. It's been in the news a bit in the past few years. And just for all the side effects I'm going to list for these other medicines, this is not the full comprehensive list. I just tried to pick out the ones that are maybe the scariest or the most common that you need to know about. So why would we pick a dopamine agonist over something else? Well, it does a pretty good job at addressing tremor and the stiffness and slowness that comes with Parkinson's. Frankly, I don't think it works quite as well as levodopa, but it does do this job. And for a lot of people, it means less frequent dosing, which is a huge benefit for some people. We typically use this a lot for restless leg syndrome. And so for our Parkinson's patients that have a lot of restless leg, this is a great, it's two birds with one stone. So sometimes we will consider it for something like that. Unlike the levodopa long-lasting formulations, the extended release versions of dopamine agonists do work pretty well. And for some people, this means that they can really cut back on how often they're taking their medicine. We tend to use dopamine agonists for people who are just recently diagnosed, they're younger. This is where they maybe have many, many more years to go in the Parkinson's journey. This is usually the type of person we're looking at starting on a dopamine agonist. The other big reason for that was because there was a study that was done, I think it was in the late 80s, early 90s, and looked at doing a head-to-head comparison of levodopa versus starting with a dopamine agonist. And if you started two groups of Parkinson's patients, one on one of these drugs and one on levodopa, it looked like you could delay the onset or the presentation of dyskinesias if they were started on a dopamine agonist first. And so that is the thinking behind starting with this class of medicines before levodopa. Though I will tell you that that thinking is actually changing quite a bit right now. Part of the reason for this changing of how and when we prescribe dopamine agonists is because a lot of this information that's coming out now. So there, for a while, has been an understanding that the dopamine agonist can cause problems with impulse control. So this is, we'll go into it a bit more, but it's issues with can't stop yourself from buying things or gambling, or there's some other behaviors like this. But we've known about this for quite a while. And I think it was unknown how widespread this would be. And so when these drugs were first prescribed, I think we weren't seeing much of this, but now that there's been more and more and more of this class of medicines being prescribed, and not just for Parkinson's, I think we are just now starting to see really what's lying underneath the tip of the iceberg, and that there really is probably more of this as an issue than was first realized when these meds were first being rolled out. And so you can see this was as recently as 2018. There are some reports about half of people on these medicines are experiencing problems with impulse control. I've seen a variety of numbers here, everything from like the teens all the way up to over 50%. And so the truth is probably somewhere in the middle. But just to know and be aware that this is a big problem for a lot of people. So what are we talking about by impulse control issue? So it's this impulsivity. So this urge to do something, to engage in a behavior because of what is the perceived benefit of that behavior, without even thinking of the long-term consequences of that behavior. And so that means there's also this inability to control it, so that our frontal brain should be there to help us avoid these bad behaviors. And that connection it doesn't work as well when these medicines are on board. Now, Parkinson's itself can do some of this, but adding dopamine agonists into the mix seems to make it much worse. And there are a few other risk factors that we'll talk about in a second. And it's this inability to resist, and you just can't stop. And it's an impulsivity that really is the characteristic here. And it really becomes, there are behaviors like this, and there's some people who will experience mild versions, let's say, of this, but it's a disorder when it's actually disrupting life and getting in the way of your relationships, and you cannot function normally because of it. That's when there's a real big problem, and some other maneuver needs to be made. And so you can see this cartoon, again, it's just this, they just can't stop themselves. And I would just make sure that it's clear that this is not a moral default of the person. this is the underlying brain chemistry that's driving it. It's not the person on the inside. I think it's an important distinction. So what kind of symptoms are we talking about? And this is the big scary ones. So we have a lot of patients who have problems with gambling. Now that can look like a bunch of different things. So that's going to the casino and blowing your paycheck. That it can look like that. But I've also had patients who overbuy scratch tickets, for example. And again, it becomes a problem if you can't buy food or pay your rent or things like this. Then it's a big issue. But there are mild versions of this that can pop through. Hypersexuality can be an issue. Again, this can look very different. It can come in forms of just thinking about it so much that it's getting in the way of functioning at work or things like this, but also as bad as things like hiring sex workers and doing behaviors that you wouldn't do normally or otherwise. Again, this isn't a moral issue of the person. It's the chemistry that's driving this. For some people, it can look like hoarding. So this desire to collect and hold on to things. This is especially a problem for women, but not exclusively, where there's overeating. And typically this is not just taking a second helping. This is overeating on a particular thing. So they will overeat crackers and hide it. And this can look very different depending on the person and the environment and the situation. But this can be a big problem for some people. The shopping as well, this tends to be women, but I know of someone who bought cars, then if there's the means to do that, the environmental situation is very different. It can look very different. There's this odd one called punding. So this is a very unique Parkinsonian symptom. And punding is this, and it's unusual, and people don't usually bring this up to their doctor. So I don't think we have a good sense of how common this is. But it's like, there's the best example I have is there was somebody who liked birdhouses. And so had just like oodles of birdhouses all over the house and loved them, took care of them, displayed them, rearranged them, but would do this excessively to the point where they weren't taking care of themselves or the family. And it's this control and this need to, it's almost like an OCD kind of behavior. And a lot of these symptoms are on that spectrum, let's say. But this is a very unusual one for dopamine. There's something called dopamine dysregulation syndrome. So this is an issue where people start thinking too much about their medicine. When's my next dose? When am I going to take it? When am I going to eat with it? How am I going to get more? And they end up sort of escalating and taking more medicine than they maybe should. This varies from person to person. This really isn't that common, but it's almost like an obsessive way of living with the medicine. And it can be a big problem for some people. But again, this is quite rare. This hobbyism. So this is overdoing a hobby. So for some patients of mine, it's things like exercise, which is great, right? But there can be a point where it becomes a problem if you're losing weight or you can't take care of yourself because you're exercising too much. Another one, listening to music. I mean, these are things where, it depends on the person, the situation with the family. Is this a problem or not? And for some people, and again, I think this is quite rare, but there could be drug addiction. Again, we're all talking about dopamine related issues, and that's where this comes into play. So again, there's behaviors and then there's the disorder. And it's a really important distinction that in a discussion that needs to be had with you, your family, and your doctors. When we say behaviors, it's more of, we see these features are coming out. But if it's impairing your ability to do things at home with your family and friends, that's where we call it a disorder. And so again, some of these things may be relatively benign. So again, exercising too much, like there's obviously good upside to that. But again, if it starts interfering with your relationships, that's a different story. And that's where things need to get changed. There are some risk factors. So we have enough information at this stage to kind of get an understanding of people who might be at more risk for developing something like an impulse control disorder. And the key thing here is all of these issues are related to dopamine. So the reward mechanisms we all have, they're all driven by dopamine. And when we're taking these medicines, we're upping dopamine. Now, it should be that the dopamine that's affecting movement is in a different area of the brain and seen by the brain differently than the dopamine that's needed for enjoyment and pleasure. But in some cases, and for some people, there is a bit of mixing and overlap. And so you end up you're raising dopamine to help with the motor symptoms, but you may actually also get some of these unintended effects. And you get this lack of the inhibition plus this feel good effect from the dopamine. It's like this double whammy for some people. And that's how we think we really can bring out these impulse control issues. There's some reason to think that people who have some depression, especially like early life depression, or folks who have had some drug addiction issues, earlier onset of their Parkinson's, that maybe they're at slightly more risk. There's a lot of variability out there, but just these are the things that we look at for somebody who's coming in. And I would weigh this in my mind in regards to whether or not to start something like a dopamine agonist, because it can be pretty hard on people, as I'm sure you can imagine.
You mentioned something about the dopamine agonist withdrawal syndrome, how common or what that might look like.
I got it coming up. Just wait. Good question. I don't want to. No, it's perfect. I'm glad you brought that up, because it's also a newer phenomenon that I think we're really only becoming aware of it in the past 5 years or maybe a bit more. I don't want to vilify dopamine agonists. I think that there is a place for them, and they are not the only drug out there that can do this. They just tend to be a little bit more responsible for this more frequently. Again, anything that ups dopamine has the potential to do this. It's just the agonists are a bit more. So just to keep in mind, and it's not common, but rarely we can see this with DBS. It depends on settings and the other underlying risk factors and the placement of DBS and all that. So it's not very common, but to keep in mind, this is not just the agonist that can do this. So let me just talk about the ICDs first, and then we'll get into the DAWS is what it's called. Again, how frequent this happens is variable. I think we are really just starting to open our eyes to this. We've now had basically, a couple of generations of patients who were started on these meds that have now aged up. And there's enough that I think we're just starting to really appreciate how frequent this actually is. And so again, I've seen ranges from the teens up to like above 50. So I think we'll get a better sense of a more solid number over time. But what's interesting is this more global perspective. It varies depending on the country, the region. And so there's cultural influences very much, as well as just environmental factors. So just to keep that in mind, it varies a good bit. And I think that's why we don't have a good handle on the number just yet. And again, there's some gender differences as to what types of behaviors come out and how they present. So I think, again, we're really starting to just appreciate this phenomenon more now. So what can we do? All well and good. It sounds terrible, but okay, what do we do about it? So the very first thing is actually, you should have had this conversation with your doctor before it's even prescribed, or if you're thinking about it, this is an important issue to just know exists. And then, if there is an issue, it's just simply recognizing it as a problem. And then you need to talk about it. You need to not be afraid. You have to talk to doctors about it, because there are things that we can help with. Again, some of these ICDs that I mentioned earlier can be embarrassing. That being said, if you don't deal with it, it won't get better. And there are some things we can do. So sometimes simply just reducing the dose, just something as simple as just knocking it back a little bit is enough. And I would recommend, typically that we do this slowly because of the withdrawal issues I'll talk about here in a second. So you don't do anything abruptly, but simply just reducing the dose can often be the answer. Sometimes switching from the more immediate release to the long acting, for some people that is enough. Sometimes just switching from one drug to another, or just going to a whole different class of medicines is sufficient. For some people, the medicine works so well, the thought of reducing it down is just not going to be not workable. And so sometimes we add other medicines to treat the other symptoms. I never like using a medicine to treat problems from another medicine, but this is an alternative route if need be. And sometimes you just remove the triggers. So, one plan I worked on with a patient and the spouse was just simply don't give them the credit card. I mean, there's just other ways in the environment to help prevent these things from happening. So it's got to be, a family invested interest. And this is, again, why you got to recognize it as an issue. You have to talk about it. You have to make it known, and then have family support and care partners to help minimize the chances of there being an issue and triggering some of these behaviors. And then if none of this works, the next step then is to discontinue the medicine altogether and look for alternate medicines to use. So I think, again, there are things that can be done. So this is why I would encourage people, please talk to your doctors and let them know if this is an issue for you before it gets too out of hand. So this was what was just mentioned here. So this was again, very new. So there's some people who have been on dopamine agonists for a while. They may have had some of these issues pop up. Doctors are now pulling and reducing down their medications with the dopamine agonist specifically. And we started to see, when we start pulling them off these meds, there's a lot of problems that start popping up. And it can be things that are typically vague. So, okay, maybe the Parkinson's motor symptoms pop up, but we were seeing a lot of other stuff. So all of a sudden, anxiety getting a lot worse, sleeping problems getting a lot worse. I remember hearing like, just don't feel right on the inside, or agitated. Some people feel like the nausea, or just being irritable, or feeling more fatigued. And I've heard some people complain of just overall aches and pains coming off of these meds and almost craving the medicine back. And so, this is, I think, particularly an issue for people who have maybe been on these medicines for a long period of time. It's the longer and the higher the dose that you're on, the harder it is to pull back. And so, this is why we do it slowly. I got to say, looking at all this together, I was really not prescribing this class of medicines very much because of these issues. I think that there's other ways for us to work around it. But again, it's enough of a concern that I've had that I really wanted to spend a lot of time discussing it today. So thank you for bearing with me. But I've seen some families fall apart, businesses fall apart, things like this, just because of this stuff. And so I want to make sure that there's, more awareness out there with it. I just want to say the DAWS, so this withdrawal syndrome, again, typically if we take it slow, we give it time, there's ways of working around this. Most people have resolution of these symptoms by 6 months. And so it's not a fast overnight thing, but just to have to, again, recognize it, make sure your doctors are aware. And then just, again, take it slow. There's no rush in this whole process. I'm done with the dopamine agonist part. Were there any questions? I don't see the chat, so I don't know if there's any questions coming in on the agonist specifically.
I haven't seen any yet, but if you do have a question about the agonist, go ahead and put it in the chat right now.
I will move on. We can answer them at the end too. So these are the COMT inhibitors. So again, 90s, there's a lot of interest in trying to extend the benefit of levodopa. And so this class of medicines was created so that you stop the breakdown, the metabolism of levodopa right at the synapse. And by doing that, that means levodopa is hanging around longer and has the ability to exert its effect for longer periods of time. So just you're making more levodopa available. One of the most common ones that's been used most frequently is entacapone. This is a component of Stalevo. Other ones that have been used in the past are tolcapone, and this is a newer one, so the opicapone. There were some liver issues, particularly around this medication. And so I think that that's something to kind of keep in mind as you're going on these meds, or if you have pre-existing liver issues, this is probably not the medicine to go on. But just so you have a sense of what these names look like. One of the big benefits of adding in a COMT inhibitor with Sinemet, again, these are really to be used with levodopa. It really can smooth out the day so that you're not experiencing the big ups and downs as much when the COMT inhibitor is on board. Now, because we are extending the benefit of levodopa, it means that levodopa is sitting around the system a bit longer. It also means that, I have to stand up, the sun's getting too bright. That means that any symptoms that you have from levodopa that are a problem are going to be exaggerated when you have the COMT inhibitors around. And so this means things like the dyskinesias, if that's a problem for you, there's a potential that they could get worse because we're just making more levodopa available even longer. That also means confusion, hallucinations. It can change the color of the urine, can cause problems with diarrhea and other GI issues. And again, there can be liver issues with some of them, but not all. So I think, again, if that's a pre-existing issue, it's something you should bring up with your doctors. And again, this isn't every side effect. These are just the more frequent and scary ones. Another class of medicine is this MAO inhibitors. I'm sure any drug commercial you hear anymore, it's like, if you're on an MAOI, let your doctors know before prescribing this medicine. These are those kinds of meds. These are frequently the most ones that have been used recently are selegiline and rasagiline. This is a slightly newer one that's been out in the market. Just like the COMT inhibitors, this blocks the breakdown of levodopa, but in a different way. This is more on the inside of the cell. And for a lot of people, this can be the single therapy that's used at the beginning of treatment. So just diagnosed, maybe a bit younger, symptoms aren't that bad. This is when we would consider something like an MAO inhibitor. It can be used with levodopa, so it doesn't have to be used alone. This is a nice add-on sometimes for meds. And the nice thing, especially for some of these other meds, it can be used very infrequently. Like there's 1 to 2 times a day dosing that can be used. So that's a big benefit of this class of medicines. Now, again, everything has side effects. So just like, and again, anytime we're increasing the availability of dopamine, you're going to get these side effects. I think you're starting to see a lot of them are very similar. So again, nausea can happen. You can get a little bit of dry mouth with this one, and that's very similar to constipation. Everything kind of dries up, and so that can be an issue. This lightheadedness is the drops in blood pressure when you stand up. And for some people, again, especially when you're getting over 70, 75, there's more concern of issues with confusion, hallucinations, these sorts of things as we get older. The other unique thing with the MAO inhibitors that if any more on them, I'm sure you've had this discussion, but there are certain foods that should be avoided. So these are foods that are high in tyramine. They tend to be a lot of things I enjoy, so that's kind of a hard thing. So aged cheeses, like veined cheeses, some cured meats, fava beans, beer, sauerkraut. I mean, these are all things that are really high in tyramine and would potentially interfere with the MAO. It actually can cause a syndrome. This is a lot less likely to happen with the medicines I just showed you because they are very selective. This is more of an issue for these more widespread MAOs. But that being said, if you're on these medicines, try to avoid lots of these cured meats and cheeses. Now, one interesting thing about the MAO inhibitors, this is a very unique feature here. There were some very early studies done in animals that suggested that MAO inhibitors could actually slow down disease progression. It was good enough that there was a study conducted called the Adagio study. And in fact, they did, it was a decently sized study in humans with Parkinson's. They started people, one group of people on the medicine, one group on just with levodopa, normal standard of care, and used them as the placebo group. And they looked at 2 different doses. And in fact, at the lower dose, it looked like when they were started on the MAO inhibitor, that it actually improved symptoms and kept them a bit lower, like improved over longer periods of time. When they looked at the higher dose, that effect wasn't there. So it's kind of one of these mysteries of the ages. There's enough hints that maybe there's something there, that other studies have been done. I think they're talking about doing even another one to see if we can find neuroprotection, again, slowing down disease progression with this class of medicines. That being said, and right now, as it stands, the evidence is still very inconclusive. The jury is still out as to whether or not this medicine could protect. But it's something to kind of keep in mind when thinking about what medicines to select for treatment. The next type of medicine is amantadine. So this is an interesting story on this one too. So it's an old flu medicine. So it was found in the 1960s, used a lot to help treat flu. And they found out people that had Parkinson's were on this med actually had improvements in their Parkinson symptoms. And so sure enough, we don't know how it's working exactly, but it is somehow upping dopamine levels. And it may be more in like the responsiveness to dopamine. And the nice thing about amantadine is it can be used by itself as well. So this can sometimes be a solo therapy, especially in early stages where symptoms may not be so severe. But we typically use this very frequently as a way to, if someone has dyskinesias, like they're taking something with levodopa and having a lot of dyskinesias, and we can't really reduce the levodopa, this is a nice add-on. It can really smooth out the day and really does a pretty decent job for some people to help minimize the amount of dyskinesias. Now, this amantadine in this formulation has been around for quite a while. This is what a lot of us have been using. More recently, gosh, it's been probably 5 years now, this GoCovery came out. So it's extended release formulation. The idea being that you only need to take it once a day to get that benefit from the amantadine over the course of the day. I think there's not yet been a study looking at the short acting and long acting head to head to see, if it really is better. I don't know if that'll ever be done, but just to keep in mind that these are, it's of interest enough to the field that this is one of the newer meds that's been on the market for PD. Now, I like amantadine because it can wake people up. For a lot of people with Parkinson's, being tired can be a big problem. And so this is a nice choice. If the side effect that you want is to stimulate, this is a nice way to do that. That being said, on the contrary side, it can cause insomnia enough that we do not usually recommend taking this medicine past like 2 o'clock in the afternoon, something like this, so that it doesn't interfere with sleep at night, because it can be a big problem for some people on this medicine. And for a lot of people, that is a reason we have to discontinue it or reduce the dose significantly. But just know it can be very activating. In fact, patients with traumatic brain injury sometimes be put on this medicine for that purpose, to kind of stimulate and wake people up. But again, the downside is you can't sleep. Again, you're upping dopamine, so the dizziness, the blood pressure issues, the nausea, the confusion, all of these are linked to dopamine being up too high. Amantadine is one that can do this a lot. So the confusion, hallucinations, these sorts of features can happen. There's really not a good way to predict who this is going to happen to. And so again, this is one of these situations where you got to talk to your doctor. This should be part of the discussion before you start the medicine. The way I advise patients is just know this can happen. I have no way of predicting if it's going to happen for you. If it does, you need to let me know, because if we stop it, it should go away. Again, this isn't an underlying problem. It's just how your body uses this particular medicine. One unique side effect from this medicine in particular is called livedo reticularis. So it's this lacy, reddish looking rash that you can see more on the legs typically, but it can go anywhere. It is not dangerous. It's not itchy. It doesn't hurt. It's just there. For a lot of people who have good benefit with amantadine, they're like, I don't care. It's working well. I'm not worried about it. For some people, you know, just aesthetically, it's unpleasing to them, and we may have to discontinue because of that. But just know this is the medicine that's doing that and giving this kind of weird look to the skin. Again, it's not dangerous. It's not considered an allergy. It's not really a true rash, but just know that it can happen. Just a few more. There's anticholinergics are another class. Again, these are an older, we just didn't have much. We still arguably don't have a whole lot of meds to use for Parkinson's, but this benztropine and trihexyphenidyl, these are meds that have been around for quite a while. And were, again, one of the earliest classes of medicines used as early as the 1900s as well. They're really good at treating dystonia. Like, this is a really good medicine for dystonia. There's some side effects to it, which I'll get into next. But this was for a mainstay for dystonia treatment, and it can help with tremor as well. It also is very drying. So if there's a lot of drooling, this is a great way to take care of those things. So again, if you're a patient that has, you know, tremor, the dystonia with the twisting motion, maybe this is a good drug for you. We really try to avoid this whole class of medicines in patients who are over 70 because it can cause a lot of confusion. And so one of the more common side effects of this is confusion and just tired. This is, there's any drug that has anticholinergic properties can make you just really sleepy. The doses we use on this are tiny. I mean, super tiny, because it can cause a lot of these other problems. And so again, it's very, very few people who I would really recommend this class for because of all of this. It can also cause problems with hallucinations, and just like with Benadryl, it can cause a lot of these same effects because of the cholinergic issues. And so it can impair memory as well. And so if there are patients who are on this and they're complaining of memory issues, it's usually like, probably need to think of something else or taking down the dose. One of the bigger issues with this is it dries everything up. So yes, it's great for drooling if that's a problem, but it dries out the mouth, which you want, but it also dries out the eyes. It causes constipation because it's drying all that out as well. And it also means you're not able to urinate as easily. So again, these are really dependent on the dose and how much you're taking over the course of the day. But for a lot of people, these side effects will prevent them from being able to get on a high enough dose here. And so again, time and place for all of these different meds. And I just wanted to give you, sort of the snapshot of the pros and cons of each med. When we're sitting in the office with our patients, it's very much weighing all of these factors in our heads as we're trying to come up with the best regimen for each individual patient. Again, levodopa is still like the workhorse for our movement disorder clinic. Almost everybody's going to end up on levodopa at some point. But what you just saw, these are a lot of the add-ons or things that we can do to really, the whole goal here is making sure our patients are functioning as best as we possibly can over the course of the day. So with that said, that took a little bit longer than I expected, but what questions are there?
Now is your time to ask questions. You can also unmute yourself and ask the question.
Please.
Are the anticholinergics used more frequently with atypical Parkinsonisms or the Parkinsonisms that are less responsive to the dopaminergic drugs?
I think it's more probably more the types of Parkinson's that come with more dystonia. So this is, I think, of more of like the early onset, like the really young onset patients who have a lot of dystonia. This is where we're really thinking about these medicines, because that dystonia can be painful and maybe not respond as well to levodopa. I think I saw there's I think Carol just sent a,
yes.
I think just found the chat. Is there a benefit to controlled release Sinemet overnight, and has it improved? So there's the Sinemet CR. We typically use this as a nighttime medicine. So it would be the pill you take at bedtime. And the idea being that it would give you just enough levodopa over the course of the evening to get you through to the morning. How well that works varies from person to person. And, you know, sometimes you just need to up the dose a bit. I think, you know, using this during the daytime is a problem because we call it controlled release, but it's really not that well controlled. And, you know, the stuff, the way it's absorbed it's not as predictable. Like with just regular Sinemet, most people know, like they know their body well enough and know what to expect and when to expect it. The controlled release is a crapshoot. Like it's a big unknown for a lot of people. So no, I don't think it's improved very much since it was first brought out. That being said, you know, I think there's other strategies that can be used. I think people are using Rytary, for example, at night for the same sort of purpose. The Duopa pump can be used overnight as well. There's ways of doing that to give you, again, the whole idea is that benefit over the evening, so your mornings are not as hard. The DBS is another way of, again, keeping that benefit overnight to make the mornings easier. I don't know if there's any other questions, but I'm happy to answer questions later too. This is a lot of information. You know, I'm happy to revisit this as well. Again, this is why movement disorder doctors will always have a job, because there's a lot to keep in mind. And I got to say, at the end of the day, what I really care about is that there's more stuff coming out. I'm glad that there's this many meds to talk about, because there really just was nothing for so long. The more in the toolbox we have, the better we're going to be able to serve our patients with these problems.
Dr.
Hey, Amber, go ahead, Karen.
Yeah, this is Karen Schaller. I didn't use my camera because I'm not ready to greet the day.
No problem.
Okay. In support group, so many people were complaining about nausea after taking whatever medication. And when I've had the flu or something, I don't have Parkinson's, but I know that ginger root, actual real root that you buy in the produce department, is a natural anti-nauseant.
Yep. So
I'm asking the question, I also know that ginger root can slow the uptake of medication, but some of the people were saying that it's so uncomfortable and it's sometimes so debilitating that they delay taking their medication. Do you know anything about how seriously that having, you know, a cup of ginger roots, tea steeped with some ginger root in it, how much it would interfere with the uptake of a medication? I mean, if it helps solve the nausea problem, is it worth trying? I'm
a huge believer in, what's the point of having medicine if it just makes you feel terrible all the time? Like there's so much that we can do. I think ginger root is a great, I mean, this has been a remedy for nausea from the beginning of time. And so I think to think about it in a slightly different way, in that if the ginger root does help, I do not expect it to have a huge impact on absorption, but it's kind of like with Coumadin, like do your life, make the meds meet up, you know, to what you need. I think there's probably a better approach. But I don't see the point. If you're home and miserable because you're nauseous all the time, what's the point of getting the levodopa to the level where you're moving around? There's got to be some balance here. And I got to say, I think ginger is an absolutely great way of doing this. There are so many formulations of ginger and ginger root. I have not heard from patients that this is a huge impact. I think that the absorption is more of a problem with protein in the diet. But again, I really am a big believer in, quality of life. It's really important. So, take that, with a grain of salt, but I wouldn't worry about it too much.
Okay, thank you.
Mm-hmm.
Amber, this is Christine. I just have one question. We of course have a population, some of whom see movement disorder specialists all the way down to being cared for by their PCP. Mm-hmm. And what we hear from the pharma reps is that it's not uncommon for a PCP or a neurologist to rely only on carbidopa, levodopa, or Sinemet to treat PD, and don't even realize, what other classes are available. Can you speak to that a little bit and encourage people to get to a movement disorder specialist?
This is like one of the most painful, I think Victor's on here somewhere, even his grandmother, same sort of thing. She never saw a neurologist, let alone a movement specialist. And I would argue it's worth going once. If you could just see somebody once, I think that is invaluable. One, just confirm that this is the right diagnosis. Just start with that. But then, what we can do, and what I did a lot of was let me just see the meds that you're on. What are the problems that you're having? Let me see if we can, get you on a better just medication regimen. And then, there's a lot that we can do on the phone with the neurologist who's closer to you or that better, or even a PCP. We're happy to typically work with them. But sometimes even just 1 or 2 visits a year can be enough to make sure you're on track, that your med regimen is as good as it can be for your needs. But it's true, there's people get stuck on these medicine regimens. The other problem is that I see people, well, I tried that and it failed. I'm like, well, what did you try? How long did you try it? What was the frequency? Because sometimes it's actually the nausea that can be a big problem for a lot of people. They get so nauseated, they just stop and then they're on nothing, or something that's completely insufficient. And that it also drives me nuts because I'm like, it could be better. Your life could be better. And so I think, working with a movement doc who knows these meds so well and knows how to work around the side effects, that's the part that I think really deserves at least one visit to a movement specialist. I know it's hard. There's not many of us. And I'm hoping that with telemedicine that maybe this gets better. But this is a big issue. Oh yeah, I just saw Bill, the double vision. I just want to mention that it's a good question. There's the dopamine agonist actually can do this as well. There are some vision problems that come up with Parkinson's. It's usually seeing double. And it's usually when you're trying to focus on something nearby, because what happens in Parkinson's is it's hard to get the eyes to move together to see something up close. But the dopamine agonist can do this as well. So if that's a big problem for you, know that to talk to your doctor about that. There are other things that can be done with glasses. But definitely mention if that's something that you've noticed. I hate it when patients love to read and all of a sudden they can't read because of this issue. There are ways to fix that. The next one was the Rytary. So I actually just heard, and I don't know if anyone else on this call has heard this, but some version of Rytary is going to go on generic next spring. I think that'd be a huge benefit. I know they were really trying hard to reformulate the Rytary, and I'm guessing some of the issues where I think we all hoped it would be 3 times a day sort of medicine, and didn't work out that way for everybody. So I know they were working hard on had to reformulate it so that it would have better, really deliver on this extended benefit. I am hearing some good things back about Rytary. I think it also took our community some time to figure out how to use it and how to prescribe it. And I think we finally are more gotten there with Rytary. So I do think it's more than just the drug itself. Some of it was just us learning how to use it and patients getting used to it as well. The only class I left off was the adenosine receptor antagonists. There's just not much out there right now. I do think it's an interesting class of medicines. It's also one that may have neuroprotective potential there as well. I think it's very interesting. And I actually am expecting we'll see more of the alpha adenosine receptor agonists coming out, antagonists coming out in the next year or so. It's a good question.
This has been extremely informative, as always, Dr. Amber Van Laar. I will email all of you the recording
so
of
much
this.
Information.
It's a lot of information. And then we will resume in January.
It sounds
good. Friday. Now, Dr. Van Laar, I'm putting you on the spot. Do you know if that will be a new topic?
It'll probably be a new topic. Okay. I actually need to check my travel schedule because I may be out of town. But the other thing I was thinking about is other treatments outside of just meds. So that was the topic I was going to try and hit on next. And at some point we should do the surgical options for Parkinson. So because that is also expanding a good bit right now. So please, if there's other topics or one of these I just mentioned that you'd prefer to see, we're all ears. There's no shortage of good stuff to talk about.
Okay, well, thank you everyone for attending. Thank you, Dr. Amber Van Laar and Dr. Victor Van Laar for the diners this year.
Really quick, one thing just came through there at the very end. It's this new idea that COVID-19 could have something to do with Parkinson's. Honestly, I think that might be a good topic for next time because this is very young science. I haven't even had a chance to look this up. I didn't even realize there was a new paper out. So
yeah, I just saw it like this week it came out. Yeah, that's actually a really good pertinent topic. We can work on that.
Okay.
Because that I'm going to tell you the story on that has changed over the past year and a half.
Yeah, and this new bit it just makes it more complicated. So.
Mm-hmm.
Okay, so more information coming. The next diner, if it works with your schedule, is January 21st. We'll confirm that in the new year, Dr. Van Laar. Thank you, everyone.
Thank you, Casey.
Thank you, everyone.
Thanks, Amber. Thanks, Vic.
Happy holidays.